Welcome to Safe Fluoroscopy Practices 2019. This module is designed to meet the annual education and training requirements for fluoroscopy safety and dose optimization techniques established by the Joint Commission. After completing this module, you will be able to explain the importance of the as low as reasonably achievable, or LARA principle. Identify radiation protection and safety features available on fluoroscopy units. Describe procedures for safely operating fluoroscopy equipment. Apply radiation dose optimization techniques for adult and pediatric patients. Describe methods to maintain image quality and minimize radiation exposure to patients and personnel. Identify the purposes of the Image Gently and Image Wisely campaigns and the available resources for fluoroscopic procedures. Fluoroscopy is used most frequently to provide real-time dynamic imaging of anatomic structures, such as circulatory movement or the motion of hollow internal structures. Today, it is being used for an increasingly wide variety of procedures in diagnostic and interventional radiology. These procedures have long exposure times, and upper gastrointestinal, or GI, fluoroscopy in particular is the most commonly conducted fluoroscopic procedure in the United States, contributing to the patient's effective dose. In that light, efforts must be taken to ensure the benefits of fluoroscopy exceed the risks to the patient and staff. Modern fixed and mobile fluoroscopy systems are available in a variety of C-arm or conventional radiography fluoroscopy configurations. They fall into two main categories: image intensifier-based equipment and flat panel detector units. Image intensifier systems are found more often in conventional radiography fluoroscopy departments, and flat panel detector units are used more frequently in interventional radiology suites. Although the imaging chains of the two types of systems have different components, both types include software programs to optimize image quality and features to reduce radiation dose to patients. All systems require operators to be trained in fluoroscopic procedures and methods to protect patients and medical personnel from unnecessary radiation exposure. The personnel operating these units must understand how to use the equipment safety features and adjust exposure settings to provide the highest quality images while keeping radiation dose to a minimum. Fluoroscopic examinations can potentially deliver a considerable radiation dose to the patient. Operators of fluoroscopy equipment must have a complete understanding of all parameters affecting patient dose and adhere to principles of the as low as reasonably achievable, or LARA concept. The goal of this concept is to minimize radiation exposure while obtaining the best quality diagnostic image possible. The fundamental principles of radiation protection are time, distance, and shielding. Radiation safety measures include minimizing the length of time the patient or others are in the path of the X-ray beam, maximizing the distance between the source of ionizing radiation and the person exposed to it, and maximizing shielding of the patient and others from radiation exposure. By following these principles, fluoroscopy operators will ensure the safety of their patients and minimize their occupational exposure. Fluoroscopy operators must have a thorough understanding of different parts of the fluoroscopy unit and ways in which proper equipment use can limit radiation dose to the patient and personnel. Source to skin distance, or SSD, is important during fixed and mobile fluoroscopic procedures, and especially during interventional radiology and cardiac catheterization procedures, because acute localized radiation effects can cause skin damage. The closer the X-ray tube is to the patient, the higher the radiation dose, given the inverse square law. For a mobile C-arm, the patient should be positioned as close to the image receptor as possible, because this increases the SSD on a fluoroscope with a fixed source-to-image receptor distance. For an interventional C-arm fluoroscope, the table should be raised appropriately to maximize the SSD, and then the image receptor should be moved as close to the patient as possible. In addition, it is important to minimize the distance that the X-ray beam travels through the patient when the C-arm is positioned at an angle. For a general fluoroscopic system, such as a GI room, the SSD is typically fixed, so the image receptor should be moved as close to the patient as possible. Fluoroscopy systems include multiple features to reduce the radiation dose to the patient. For example, Copper filtration helps remove low-energy X-rays from the beam before it reaches the patient. Additionally, beam-limiting devices are used to restrict the size of the X-ray field, thereby controlling the amount of radiation exposure to the patient. Most fluoroscopy systems allow the operator to reduce the field size by using lead shutters or collimators. Collimators block out bright areas, such as lung or other low-density regions, to provide better resolution of the surrounding tissues. Limiting the beam size also produces many benefits that lower radiation dose. Because less tissue is irradiated, the patient's total dose is reduced, and the dose to imaging staff is decreased because there is less scatter radiation. In addition, the noise added to the image from scatter radiation is decreased. Overall, improved image quality is a major advantage that comes with the collimator use. Fluoroscopy operators should manually collimate to the area of interest and avoid exposure of radiosensitive organs such as the eyes, thyroid, breasts, and gonads when possible. A complete understanding of exposure control devices is the best way for fluoroscopy operators to significantly reduce patient and staff radiation exposure. 3 basic controls regulate the quantity and quality of the X-rays produced: the peak kilovoltage, or kVp, the milliamperage, or mA, and the exposure time. Of the 3, reducing the amount of time the X-ray beam is on is most critical to limiting the radiation dose. Additionally, fluoroscopic mA is kept as low as possible, generally 0.5 to 3 mA. The use of a higher kVp, between 85 and 125 kVp, will reduce the fluoroscopic mA required to obtain adequate image brightness, thereby reducing patient dose. Current fluoroscopy units use either a manual or an automatic mode to produce images. When the manual mode is selected, the radiation exposure rate is independent of patient size, body part imaged, and tissue type. However, these factors adversely affect image quality and brightness when the operator pans across different tissues with different thicknesses. Therefore, most fluoroscopic procedures are performed using the automatic mode rather than the manual mode. Automatic dose rate control or automatic exposure rate control systems modify exposure parameters such as mA and kVp to maintain image quality and lower patient exposure. The United States Food and Drug Administration, or FDA, regulates the construction of all fluoroscopy systems and limits the maximum entrance skin exposure to 10 rads per minute. The use of a higher tube current mode, such as boost mode, is appropriate for situations requiring high video image resolution, but at the cost of increased radiation dose to the patient and staff. In general, an audible signal indicates use of the high-level mode. The boost mode has a limited exposure rate of up to 20 rads per minute compared with the maximum of 10 rads per minute for normal automatic exposure rate control modes, and a maximum of 5 rads per minute for manual mode. The use of grids in fluoroscopy studies might not be necessary, especially when imaging with a reduced field of view or when examining a small patient or body part. If the fluoroscopy unit has a removable grid, operators should consider removing it during pediatric exams in particular. During fluoroscopy, radiation exposure is directly proportional to the length of time the unit is energized, called the beam on time. Increasing the period of time the X-ray unit is on increases radiation exposure. Fluoroscopy units do not contain a fail-safe switch or automatic timer to terminate exposure like regular X-ray units do. Therefore, favorable clinical outcomes hinge on the careful use of fluoroscopy time and good judgment to balance image quality and patient dose. Continuous use of fluoroscopy maximizes the radiation dose to the patient. If the operator uses fluoroscopy intermittently and for the shortest time needed to make the required observations, the patient's total radiation dose will be lower. Additional ways to reduce fluoroscopy time include stopping patient exposure when not viewing the monitor, pre-planning images, avoiding redundant views, and acknowledging fluoroscopy timing alerts during procedures. Before beginning a procedure, team members should plan and communicate procedural details such as the number and timing of acquisitions, contrast parameters, patient positioning, and suspension of respiration to minimize unnecessary exposures. The fluoroscopy operator should always position the detector over the area of anatomic interest prior to depressing the fluoroscopy pedal. For example, If an upper GI study is being performed, the experienced operator will avoid turning the X-ray beam on over the pelvis of the patient. There is no need to radiate the patient as the detector is moved from the pelvis to the esophagus. The operator also should minimize overlapping the field of view on subsequent acquisitions. When evaluating fluoroscopy images, the operator always should be looking at the monitor when the fluoroscopy unit is functioning. One of the simplest ways that an operator can decrease radiation exposure time is by using the last image hold function. Last image hold, or LIH, is an equipment feature that retains the last image of a fluoroscopy sequence on the monitor after the fluoroscopic pedal is released. Prior to the introduction of LIH, fluoroscopic images only appeared on the display monitor, while the fluoroscopy pedal was depressed and the patient was irradiated. LIH allows the operator to study the displayed static fluoroscopic image as long as necessary without further irradiation to the patient. The FDA has established several regulations concerning the LIH image. The system must allow any factors that can be selected by the operator to be manipulated before the fluoroscopic exposure occurs. Examples of these features include the number of images, method of combining images, and radiographic technique factors. Pre-planning images and proper use of the last image hold function can reduce total fluoroscopic time by 50 to 80%. Fluoroscopy operators should use pulsed rather than continuous fluoroscopy modes when possible, with as low a pulse as possible to minimize patient dose and exposure times. Pulse fluoroscopy modes allow the operator to view images on a time delay instead of constant viewing, which decreases patient exposure and can provide better images by preventing motion blur. Pediatric cardiac studies require frame rates of 30 pulses per second, while adults are typically imaged at 15 pulses per second. The pediatric studies require 30 pulses per second because infants and children have a more rapid heartbeat than adults. Non-cardiac interventional studies typically require 15 pulses per second for pediatrics and 7.5 pulses per second for adults. General fluoroscopic studies of the GI tract or bladder can typically be performed with frame rates from 1 to 4 pulses per second for either pediatric or adult patients. Systems that can pulse the beam at less than 10 pulses per second can result in up to 90% less exposure compared with non-pulsed systems. The FDA requires all fluoroscopy systems to have an exposure timer display with an audible signal. This allows the operator to remain aware of the beam on time and notifies them of significant exposure times. The alarm sounds at regular intervals, usually 5 minutes, and must be physically reset. If the operator becomes concerned about radiation exposure time, he or she should alert the practitioner. Additionally, by stating the fluoroscopy time when the alarm sounds, the operator can ensure that everyone in the room is aware of the cumulative radiation exposure time. An important concept that affects radiation dose and image quality during fluoroscopy is the proper use of magnification modes. In an image intensifier system, usually 3 to 5 magnification modes are available, and dose typically increases with greater magnification. When using magnification or a smaller field of view, the focal point is farther away from the output screen, and the amount of exposed area on the input screen decreases. Because a smaller area of the input screen is used, there is less minification gain. To keep exposure to the image receptor at an appropriate level, radiation exposure to the input screen must be increased. The fluoroscopy system automatically adjusts factors such as MA and KVP, and the result is more radiation exposure to the patient. The additional radiation dose raises the patient entrance skin dose and can become quite high, especially when small fields of view are chosen. Fluoroscopy operators should select a larger field of view, minimize the use of magnification modes, and use digital zoom whenever possible. Theoretically, in a flat panel detector system, magnification mode does not increase radiation exposure as long as binning isn't used. In other words, the dose levels of the patient would remain unchanged, no matter what field of view size is used. Because the size of the detector elements is constant, the amount of exposure needed to activate each individual element is the same for all field of view sizes. However, in practice, An observer will perceive more image noise when magnification mode and a smaller field of view are used in a flat panel detector system. To compensate for the perceived image noise, most flat panel detector manufacturers increase radiation exposure to the detector element and therefore to the patient for magnification modes. Nevertheless, the increase in radiation exposure for magnification is significantly less for flat panel detector systems than for image intensifier systems. In the United States, all new fluoroscopy systems are required to have dose area product meters. The dose area product measurement incorporates both radiation dose and the volume of tissue irradiated, as is an indicator of radiation risk. These meters work with other dose calculating systems to monitor and display the total amount of radiation exposure to the patient during the procedure. Practitioners then have a reference to help them avoid unnecessary exposure to the patient during procedures. The dose delivered during fluoroscopy should be limited to 0.1 gray or 10 rad per minute under normal circumstances. Patient dose estimates should be documented in the patient's medical record and also in a collective patient dose database. In addition, some states require careful estimates of patient dose at the completion of interventional fluoroscopic procedures to assist the medical imaging team in providing appropriate follow-up patient care. Radiation-induced skin injuries as a result of interventional procedures include temporary epilation, dry and moist desquamation, dermal necrosis, and secondary ulcerations. The FDA recommends documenting any skin dose of 1 to 2 gray or 100 to 200 rad, and noting the location on the skin with a diagram, annotated photograph, or narrative description. To ensure quality of care and maintain legal standards of care, the following items should be documented for all fluoroscopy procedures: radiation dose, fluoroscopy time, contrast media and IV medication administration, immobilization techniques, safety measures, and catheter insertion and removal. All personnel should participate in documentation to enhance communication, reduce risks, and improve patient care. Medical imaging is critical in diagnosing illness in children and ultimately improves patient outcomes. However, it is important for fluoroscopy operators to ensure that radiation exposure to children is optimized. Radiation protection is of particular concern during fluoroscopy because pediatric patients are more radiosensitive than adults and have a longer expected lifetime for the effects from radiation exposure to potentially develop into cancer. In addition, pediatric patients receive a larger radiation dose than is necessary to produce a useful image when the fluoroscope uses equipment settings designed exclusively for adults. According to the FDA, fluoroscopic equipment should be designed for patients of all sizes, both adult and pediatric patients, and exposure factors should be selected based on the clinical indication, patient size, and anatomical area being examined. The challenge in pediatric fluoroscopic imaging is to optimize the performance of the fluoroscopy unit along with the control of the equipment by the operator so that the child receives a properly managed radiation dose. Operators should identify practices that reduce radiation dose to the child, apply equipment modifications that reduce the child's dose, and adopt appropriate pediatric practice guidelines. Following ALARA means using pediatric protocols when appropriate and modifying exposure factors if necessary. To promote responsible practices in pediatric imaging, the Image Gently campaign was developed in 2007 with the objective of raising awareness about methods to reduce radiation dose during pediatric medical imaging exams. The campaign is an initiative of the Image Gently Alliance, a coalition founded by the Society for Pediatric Radiology, the American Society of Radiologic Technologists, the American College of Radiology, and the American Association of Physicists in Medicine. The Alliance has now grown to more than 100 national and international organizations. The Image Gently website at www.imagegently.org provides parents, radiologists, pediatricians, medical physicists, the media, and imaging personnel a range of resources that explain radiation concepts in understandable terms. The site also includes downloadable presentations, patient brochures, a log for recording radiation dose received during an exam, checklists for reducing dose, and an outline of dose reduction and quality maintenance steps to take in the department. For fluoroscopy procedures, the phrase pause and pulse reminds operators and practitioners to use child-sized techniques, choose the lowest pulse rate possible, and consider alternate imaging modalities such as ultrasound or MRI when appropriate. Thousands of healthcare professionals and facilities have taken the online pledge to image gently when performing pediatric imaging exams. Following the success of Image Gently, several professional organizations, including the American College of Radiology, the Radiological Society of North America, the American Association of Physicists in Medicine, and the American Society of Radiologic Technologists, created the Image Wisely campaign to address radiation safety concerns in adult medical imaging. The goal of the campaign is to limit radiation exposure delivered by medically necessary imaging studies and to eliminate unwarranted procedures. The Image Wisely website at www.imagewisely.org provides resources on fluoroscopy topics, including recommended protocols and techniques, how to develop a safety culture, patient education materials, and specific equipment information. Fluoroscopy often results in the most occupational radiation exposure of any radiological imaging modality. In addition to protecting the patient from radiation exposure, the fluoroscopy operator must protect all staff present for the procedure. The National Council on Radiation Protection and Measurements recommends an annual occupational effective dose limit of 50 millisieverts for the whole body, as well as equivalent dose limits of 150 millisieverts for the lens of the eye and 500 millisieverts for the extremities. The International Commission on Radiological Protection, however, suggests the maximum equivalent dose for the lens of the eye should be 20 millisieverts per year. Thus, the proper use of radiation by operators of fluoroscopy units is critical, and personnel must have appropriate training concerning the potential for radiation exposure during each examination. Operators and personnel should always keep their hands out of the path of the X-ray beam and maintain as great a distance as possible between themselves and the source of radiation. The divergence of the X-ray beam from its source has less radiation per unit area, so increasing distance decreases radiation exposure. Maintaining as great a distance as possible from the source of radiation is the easiest form of radiation protection, especially during fluoroscopy. Because the most common source of exposure to medical personnel in fluoroscopy settings typically is scatter radiation from the patient, personnel also should maintain as great a distance as possible from the patient during acquisitions. All individuals who are in the vicinity of the procedure should wear protective apparel such as lead aprons, thyroid shields, and leaded eyewear to shield them from ionizing radiation. Additionally, all non-essential personnel should step out of the room or remain behind protective shields during acquisitions. The use of automatic contrast injectors also significantly lowers occupational dose because the staff can leave the examination room during contrast injections and X-ray exposures, thereby increasing the distance from the X-ray source and shielding from room walls. If hand injections are necessary, extension tubing should be used so that the operator can remain as far away from the X-ray source as possible. This concludes Safe Fluoroscopy Practices 2019. You should now be able to explain the importance of the as low as reasonably achievable, or LARA principle. Identify radiation protection and safety features available on fluoroscopy units. Describe procedures for safely operating fluoroscopy equipment. Apply radiation dose optimization techniques for adult and pediatric patients. Describe methods to maintain image quality and minimize radiation exposure to patients and personnel. Identify the purposes of the Image Gently and Image Wisely campaigns and the available resources for fluoroscopic procedures. This content is an excerpt from ASRT's Fluoroscopy series. If you would like to complete the entire series for CE credit, please visit www.asrt.org/fluoroscopy.